today we are going to look at ethics, public policy, public health in medical genetics. We start by defining a few terms. What is ethics? And this is usually a set of guidelines for morally acceptable conduct within the theoretical framework. And now, when we say bioethics, it is now a study of ethical and moral principles or implications of new biological discoveries or biomedical advances, as in the fields of genetic engineering, drug research, forensics, medicine, etc. So the ethical and moral implications when it comes to biological and biomedical advances. In medical genetics, it's an area of science where we have medical professionals involved in the diagnosis, treatment, and information on genetic conditions. And it involves people like geneticists who are medical doctors involved in examination and diagnosis, and genetic counselors who provide information and the option of testing individuals with or at risk of genetic disorders. They also provide supportive counseling, and they are educators for other healthcare professionals and the general public concerning genetic conditions. So there are ethical issues that the field of medical genetics will raise, and these are inclusive of the fact that information is familiar, not individualistic. So the issue of privacy of genetic information from institutional or even family third parties. So the information about my genetic condition, usually there is that conflict of should it be kept private and not exposed to my family members as well as other third parties. Another ethical issue is implications for reproduction, because genetics usually will indicate or give effects on future generations, and it could even advise families not to conceive or marry. So that has a reproductive effect that raises an ethical issue. The issues of emotions, emotional impact on individuals once you discover genetic issues, because these are permanent issues that may not be corrective. We have predictive value of tests may be limited. Of course, there is no test that is 100%. Most of them that exist would be probably over 90%. But now, if you declare somebody having a genetic disorder with in mind that these tests are a bit limited, that also raises issues of the predictive value of the test results. Then the value of genetic information vis-a-vis the medical benefit. Knowing versus how it will benefit me after knowing. Is it easier to remain without knowing? Then sometimes they are associated with stigmatization, because if you're discovered to have a certain genetic disorder, you'd be stigmatized by society even against certain jobs. There is also the issue of voluntary versus mandatory counseling, especially now when it involves maybe parental choices versus a child's choices of knowing their status. Full disclosure of information in terms of confidentiality versus duties to relatives at genetic risk. Sometimes you have discovered you have this genetic issue. Now, should you disclose to other relatives who are likely to be sharing, like your siblings, your parents who may be at risk and maybe they haven't shown any symptoms, among other issues? So the confidentiality versus your duty to others who are at that risk. Directive versus non-directive counseling in terms of, am I the one who will receive the information versus using other people to give me the information, and that can also be connected to full disclosure. The non-medical uses of prenatal diagnosis, including selection of sex of the child. So this is a non-medical, it doesn't solve any medical or have any medical benefit. So the issue is it ethical to select the gender that you want your child to have because of the predisposition of genetical conditions among or across gender? Then other issues in research like recombinant DNA technology, gene therapies that are trying to correct issues of genetic disorders. So there is ethical issues concerning if they are okay, if they are right and morally acceptable. So risks of genetic testing, we have detection of non-paternity. Now you do genetic testing and then discover that the father you knew is not your father because of non-paternity. That is a risk. Issues of stigmatization, including survivor guilt, insurance, employment, and immigration discrimination due to genetic testing. Of course, we've talked about emotional or psychological harm, then effect on family members and relationships. Now, to solve or to try and handle ethical issues that arise, we usually do have 4 principles of bioethics or ethical principles that help us or guide us into what we should do. One of them is respect for autonomy of persons. And autonomy means being free to make your own decisions without coercion. So, in medical genetics, we respect self-determination of individuals and protect those who don't have so much autonomy, like children, and assist them and make them feel that they have made their own decision to know their genetic status. So in autonomy, you can ask somebody, have you thought whether you want to take the genetic test? And then the person says, yes, I have. And that means you have allowed them to freely choose based on adequate information that you have provided and you have not coerced them in any way. The other one is what we call beneficence. Beneficence is doing the right thing, okay? By ensuring that as a geneticist, you promote the well-being. You give the highest priority to the welfare of the person to maximize the benefits to their health. So if you find that something does not have any medical benefit, then you forego. So you ensure that you act to improve the patient's welfare. For example, in this situation, we're having this geneticist saying it is scary to know that I have such a high risk of colon cancer, and then the person encourages them that your risk can be greatly reduced with regular screening and removal of polyps. So assure them that whatever the test they have done, then there is still hope. It's not all gloom. There is something that is going to benefit. They will benefit from the situation. Non-maleficence, and this means you do no harm. You avoid where necessary or prevent harm to persons by at least minimizing the harm. For example, ensure that you have discussed well what does it take. There are injections involved. Are there invasive tests that are involved? You discuss all the issues they have and allow them to ask as many questions as they have to ensure that they feel comfortable with the intervention. Then the last one is what we call justice, being fair, give equal benefit, and distribute burden. And this it will involve the rule of fidelity, that is, keep to all contracts and promises. Be clear. If this is what you have agreed, keep to it. The rule of veracity, tell the truth. Don't hide anything because hiding would mean discovering in the future. Ensure confidentiality. Do not disclose information that has been shared in an intimate manner. And then the rule of privacy. which requires that you respect limited or restricted access to the person, okay, especially in the course of the intervention. We have other ethical dilemmas in genetics. That is the issue of the right to know or the right not to know, the duty to harm, to warn or inform. Sometimes you have discovered something that you are not actually testing. So the question is, do you warn or inform? The duty to recontact. You have tested somebody, discovered they have this. Should you follow up, recontact them and know how they are doing? Then testing without informed consent, because sometimes the situations are the person has no relatives, they don't have they are in probably a medical fix that they cannot decide for themselves. So sometimes you could be faced with the dilemma of do you test without consent, adoption issues. That is now when parents are planning adoption, pre-adoption testing, post-adoption duty to warn, you know. And now preventing ethical dilemmas in clinical practice can be difficult, but usually what you do as an intervention for these dilemmas is ensure detailed genetic counseling, talk, attempt to anticipate all the dilemmas that may arise and address them with the patient. That is, non-paternity may be revealed. Tell them that there is that possibility. Are you ready to know that there could be a possibility of non-paternity risks that may apply even to other family members? Now you have known there could be other family members. Discuss with them and disclose information to the family. Agree on the disclosure and then agree on the disclosure to physicians and also to insurance, because some of these medical uh, conditions may need long-term financial implication. So the issues of insurance, should we disclose? So discuss this intensively. And then also always ensure informed consent. This helps you not be in any ethical dilemma and ensure it is written. It will help you refer to in the future. And then keep up current with the published public policies, because even the public policies usually will dictate and keep updating on how you should handle certain issues when it comes to clinical practice. Just an example of a dilemma is this predictive testing for Huntington disease. So you have Julie, who is 25 years, and she's requesting for predictive genetic testing for Huntington disease, which is a fatal neurodegenerative disease that led to her paternal, connected to her father, grandmother's death at the age of 65. So she wants to know if there's a possibility that she may get this in future. So her dad, who is about 45 years old, is alive and well and is not interested in genetic testing for this condition. What do you think? Should you offer this girl the testing? So the fact is that autosomal dominant inheritance is 50% chance to inherit from an affected parent. Therefore, the father's risk is 50 because the mother had the disease, and therefore for Julie, her risk is 25. So the possible test outcomes once you test this lady is that if she's positive, then her father is actually 100% positive, and any of her siblings will be 50-50%. If she's negative, the father's risk remains 50, and her siblings is going to be 25%. So you can see that her testing is going to also affect the father and affect her siblings. So the ethical dilemma here is Julie's right. She has autonomy to decide to have the testing to determine her own status. But also her father's right also has autonomy not to know certain information about himself, as well as her siblings. So sometimes you are caught up in the middle of such a dilemma. But in this case, remember, if you get informed consent, then Julie has a right, and then you can agree if you do disclosure to the father or not. So now we have been talking about bioethics in clinical practice, but we do have what we call bioethics in public health. Okay. So bioethics, we have said, explores ethical issues and analyzes the advances in health-related sciences like biology, chemistry, medicine, and it brings together the ideas of philosophers, physicians, lawyers, scientists, and public health professionals. Now, public health greatly benefits from bioethics by broadening its primary focus of bioethics from now an individual autonomy and clinical care to contextual issues in healthcare decision making, the value conflicts inherent in population based. Now, in public health, we look at not just individuals but population based programs and social and structural determinants of population health. So, the key difference between ethics and public health ethics is that we have four main principles that underlie medical or genetical ethics. That is what we talked about: autonomy, non-malfeasance, beneficence, and justice. And the ethical principles in public health address issues such as interdependence, community trust, fundamentality, and justice. So we talked about genetic ethical issues. Now we look at public health ethical issues. For example, one of them is the responsibility to protect society, the responsibility to protect individuals at a population level. Then we have individual versus community rights. We have government responsibility in genetical issues that are public health interest. We have what we call corporate responsibility, then right to health care. Then we have personal responsibility and self-care, quality of care that is received by public uh, communities, freedom of choice, then acting on evidence versus not acting at a population scale. Now, you realize that public health is now guided by public health policy or biopolicy, which are now laws, regulations, actions, and decisions implemented within the society in order to promote now the wellness of society and ensure that specific health goals are met. Public health policies can range from formal legislation that has been done to now community outreach efforts that are within smaller populations. And these policies play an important role in multiple sectors, including healthcare, going now to insurance that we had as an ethical issue in genetics or medical care, education, agriculture, business. It's more cross-cutting. And then these policies play a vital role in the general wellness and safety of population versus or vis-a-vis the individual, as we had reflected earlier. And based on the given needs of a community, public health policy establishes clear goals and solutions towards total health, from quality health care, available health care, affordable health care, etc. So public health law or public biopolicy and ethics, we have the government having the obligation, the principle that the government has the obligation to protect the health of the population. The power of government to legislate, tax, spend, regulate, and even punish anyone in any of these sectors that does not confine to the wellness of the society. Then restriction of personal and business liberties, e.g. seatbelt laws, smoking restrictions versus human rights. Then they have the economic, social impact of intervention versus non-intervention, e.g. tackling inequities of the poor and the rural populations. Then the laws enacted by legislative bodies They are also involved in court decisions, public scrutiny, and accountability. Then we have what we call individual rights and public health ethical issues. So now the right to quality health is an individual right versus now what the public health or policy or governments are able to do. Then we have provider responsibility to act for the benefit of the client. We have issues of euthanasia where an individual wants to decide versus public health, confidentiality, right to privacy, issues of informed consent, issues of birth control can be controlled by public health and you know also raises individual rights, supply and distribution of resources for health, incentives and disincentives in healthcare that probably could be leading to certain interventions that are um, affecting individual rights, issues of equity, social, ethnic, and regional, and then we have social solidarity. So those are public health or how ethics now cuts across into public